All right, hello. My name is Paula, and we're just going to sit and chat. I'm here with another worker with our company, and we're just going to talk about things that we've experienced in the world of care and communities. My name is Paula, like I said, and as far as experience being an administrator, I think I've been doing that now for 35 years, but actually started when I was 18, and I'm 64 now, so is that 47 years? That's 47 years. Very scary. Can't believe I lived this long. But yes, so I started working with people with developmental disabilities, and now I'm working with both people with developmental disabilities and the aging population. And so now I'm giving it to Dana. Take it away.
Yeah, hi, I'm Dana, and I came to long-term care in a roundabout way, but for the last 17 years plus, I've been working with an elderly population in assisted living, and I'm really passionate about giving great care to people, about person-centered care, about making sure that individuals get respect and dignity and all that good stuff. In my past, I've worked in the medical industry, doing some hospital medical records work, and then I went into hospice as a hospice rep and discovered assisted living through my work there, and really fell in love with it.
I did not know that part. All right, well, we are both very passionate about this, and I think when we do our trainings, that comes out. Do you want to talk a little bit about behavioral expression?
Yeah, so I like to call the bad old days when in a lot of, for example, skilled nursing facilities, you saw people who were sedated pretty much day and night, and that was considered a standard of making them cooperate with their care.
Right.
But we know that especially in the elderly, psychotropic drugs are bad. There's definitely a time and a place for medication. But when you're giving people things like Ativan and they're 80 years old, you're increasing the risks of falls. When people fall, they break their bones. When they break their bones, it can be the beginning of a really bad outcome. We used to use drugs for behaviors, and people used to say, oh, they're having a behavior, let's get a PRN. And the approach is outdated and hopefully not practiced as much. When somebody has a behavior, we're teaching people not to call it a behavior. What is a behavior? You're behaving. Right. You're sitting in a chair.
We're both behaving.
Yeah.
Right. It can be positive, neutral,
you're nodding
or negative.
your head. You know,
right.
if you scratch your knee, that's
right.
a behavior. So we're looking at what is the person doing. Are they pacing? Are they screaming? Are they crying? You know, currently the standard practice is to document the behaviors, the behavioral expressions, and to say what it is.
Right. What does it mean?
Yeah, and what was the person doing? Can you draw a picture of it?
Right.
Was he punching the wall?
Right.
That
Rather
is
than saying aggressive
agitated.
or
Right.
or non-compliance. Oh, I love that.
Exactly.
One.
Non-compliant with what?
Yeah.
Making your job easier.
Exactly. Right. Because you're the boss.
Right.
Right.
Right. But yeah, we're really trying to get toward knowing what came before that particular behavioral expression. Was there an antecedent? Was there something? Is there a time of day that it happens? Is the person in pain? Are they hungry? Did they just have a visit from a loved one and now they're having some kind of behavioral expression? And what do they need?
Right.
Do they need some kind of attention, and how do we give it to them?
Right.
And we keep track of that.
Right.
And, you know, with the goal being fewer drugs.
Absolutely. 100%. Yes. Because I think that the whole practice of giving drugs was initially to make the job easier. And, you know, I'm thinking back at a time like in the 60s, my great-grandmother was in a nursing facility, and she died there. And her care there was horrendous. My grandmother and my mom, when they would visit her, say that she was in a wet diaper, a wet bed, every single time they went there. And gifts that they would send to her weren't there, but they would sometimes see them on the nurse's station. So it was just, and I think she eventually died of pneumonia, but so the care there was horrible, and she was constantly medicated, not awake when she would have visitors. And I think that is what it was like then, but now we recognize that everybody should have a quality of life until the day they die. We don't just stop because that person is not young anymore and, well, they need care, so it doesn't really
Yeah.
matter. We just want to make things easier for us. So, yeah, there has been this move in the last, I don't know, 10, 20 years, maybe not going back that far, to understand why there is a behavior. Let's say if I have a behavior and it's because something got triggered in my head and now I'm maybe not behaving the way I usually do. I don't want to be judged. Well, look at what she's doing. You know, she's not a nice person. She's not a good person. Wait a minute. There's a reason I'm doing this.
She's being stubborn.
Right,
She's
I'm
giving me
being
a hard
stubborn.
time.
Yeah, but you don't know what I was going through.
No.
Right? So, yeah, that's why we should seek to understand what the behavior
Yeah.
means, what it's trying to say. What's the problem with the care is what we should be asking.
Right. And that thing about your grandmother
Yeah.
in the nursing home, that contributes to why 80% of people want to age in their own
Right.
home, because they're thinking back to visiting loved ones in the
Right.
past. And it still exists. There are still places that are not doing things the right way.
Oh, I know.
They're still using, the goal is to have, I think, 10% or fewer of the population on psychotropic or PRN drugs. And you can still walk into any facility and find that they're 50 and 60% of them are taking Ativan. Hopefully we're going the right way, but this is why, you know, a lot of this generation who's getting close to needing care maybe are terrified of it. And people make promises, you know, people will promise their parents that they'll never put them in a facility, but then if something like dementia happens,
We have no
and
choice.
it's practically impossible for any one of us to take care of another adult around the clock who needs
Right.
full care.
And when you think about it, like if it's an adult child, for example, my grandmother just died last December, and she was 102, and I think I already told you that. But my mom is 85 years old. And so, you know, my mom was like, no, I can take care of him. I'm like, no, Mom, I'm afraid that you're going to fall and get hurt or something, you know, because my mom did have a fall, but she was always trying to get her up and hoist her up. And even though my grandma became very small, 105 pounds, still, that's a lot
Dead
to
weight.
pick up when you're 85, 86 years old.
Yeah.
So yeah, it becomes that, it gets to that point where you kind of have to. And thankfully, the doctor said, no, we're not sending her back with you. You need to find her a home. So I was so glad about that.
Yeah, yeah. People will always need care. Somebody
Right.
will. With the growing life expectancy that is happening to everybody around the world, the main cause of dementia, let's be real, is old age. There are more and more elderly people, and either they don't have someone to care for them, or it's too hard. So there will always be a need for facilities.
I just want to say that there is a difference between cognitive decline and dementia. And only because I have witnessed people writing down, oh, they have dementia, asking, did you get a diagnosis for this? No. Well, why do you have dementia? Well, because they're losing their memory or because they're
Which
old.
isn't-
Yes.
isn't a
And
thing.
it's not true that everybody that ages is going to get dementia.
Fair? Yep.
Yeah.
That is true.
Challenging behaviors. So talking about that term, challenging behaviors, because I hear this all the time. And if we could change that term, challenging behaviors, what would we change it to?
Still behavioral expression.
Okay.
Who are they challenging? You because you're
Right.
trying to get something done and they
Correct.
don't want to do it? Are they hurting themselves? That's definitely a challenge. But what are they doing and what are they expressing that we need to help them with?
Right. So, yeah, it's a challenge to the person who's trying to do the work or the task, but it's a fear or a misunderstanding for that resident. So, if I could change that term, might be misunderstood communication.
Yeah,
That works for me.
yeah,
I would like that much better.
yeah.
We don't understand Paula's communication, rather than Paula has some challenging behaviors.
And it feels different to you
Yes.
when you're talking about yourself, and that's person-centered.
Right.
You can't have enough training and creativity, and experience helps with staff knowing how to address whatever's going on.
Right.
And I had somebody in a continuing education class the other day wanted me to explain to her how to get her resident to take a shower. She was like, but you haven't given me an answer. And I was, I was saying, you know, I don't know that person. I know I can think of some things you can try. You can try reasoning with a person. You can try bribing a person. You're not going to hurt them if they think they're going to get a cookie after the
Right.
shower and get it.
Right.
Music, but the majority of the time it's being patient and treating them like and smiling at them, talking to them.
Right.
But I don't know. I don't know what your person needs. You have to try different things.
Right.
And sometimes it's not rocket science. I had a resident one time who had these bad episodes in the afternoon. She would get agitated, so to speak. She was kind of pacing around, exit seeking, didn't want anyone to mess with her. She didn't want to do any of our activities. And one time she was screaming at the staff, "Get away from me." And I come out of my office and she's got 5 people surrounding her going, "Come on, no, stop, come over here, you know, relax." And I was like, guys, she's speaking English.
Right.
Get away.
Get away.
What
yeah.
more do you need? What we
Right.
needed was to withdraw,
Right.
watch her from a distance. She was okay. She just wanted to, you know, she would walk around in the parking lot, which was fenced. And we just need to keep an eye on her.
Right. Yes.
Like-
yeah. You said that, and it triggered a memory. I don't know if I can say his name, but Dr. Power
Yeah.
told a story about he was in a home, and there was a gentleman who fell on the floor, and there was a bunch of staff around. So they all ran towards him. He was on the floor, and they were all trying to get him up, pull him up. And he was then yelling and throwing his arms at them and throwing fists and screaming. And they didn't stop because this just alerted them even more, and they were trying to get him off the floor, thinking that all this screaming and fist throwing is because he's on the floor. Well, there was the doctor that was still in the home at the time, and he went over there and he said, "Everybody, like, back away." And what he did was he got on the floor next to the gentleman, laid down next to him, and he just said, "Hi, Al, how you doing?" And he goes, "Not so good, Doc." And he goes, "All right, we'll just stay here until you're ready to get up, but you let me know when." And then he said, "I'm ready to get up now." And so the doctor gently helped him up. So yeah, it can, when you're on the other side, it can be very upsetting and shocking.
And that's a typical reaction
Right.
from a lot of caregivers
Right.
is fix the situation, pull the person up, and they would look at you like you're crazy if you
Right.
went and laid down on the floor.
Right.
But
It worked, yes.